Right, welcome everyone to noon seminar. My name is Allison West. I'm an associate professor in the department, and I am so thrilled to introduce Dr. Christy Bethell. I did not prepare a lengthy bio or introduction because I know she will introduce herself, but she really is a national leader in the whole person, whole family, whole community health, something like that. But just really a national leader in really so many areas related to measurement and really building and transforming systems. So welcome, Dr. Bethell.
Thank you. Oh, I'm so honored to be here today. And I just want to say it's February 2nd, 2020, February 5th, 2025. It feels like we're living in olden times to some extent. We're living in future times to some extent, but I think no matter where we are and whatever we're dealing with, we need to keep our eye on the possibilities and staying the course. And so that's really my goal today. But I also want to recognize the context that we're in. And I think if anything, it makes what I'm going to be talking about today even more important. And I also know that many of you share a lot of what I'm going to already talk about. So I just want to let you know that I welcome your comments and questions as we go and reflections as we continue to stay the course. And I'm focusing on promoting early and lifelong health of children and youth as the core well-being of the well-being of our population. And thought that it might be useful for you to hear a little bit about the new National Academy of Science, Engineering, and Medicine launching Lifelong Health Report that I worked on. It was really intense, actually, for a couple of years, and synthesized a lot of what was going on before. So I'll say a little bit about that and then link it specifically to the Engagement and Action Framework, which is a statewide integrated framework for getting systems to work together on behalf of promoting the health promotion and well-being of children. And Cynthia's been at this forever and many of you as well, but hopefully we can go on. Okay, let me see here how I get this here and then go like that. Okay, so as Allison said, I'll say just a little bit about what the Child and Adolescent Health Measurements Initiative is. We got started in 1996 as a project to develop performance measures under CHIP and Medicaid, and it turned into a life's work because it turned out at that time we had zero measurement for children, youth, and families. We didn't know how to even define kids with special needs, or we hadn't translated anything into measurement. So we didn't really have data either at a system level or the population level, really, except for birth and death and data, things like that. So I got into this a long time ago. And if you want to read more about it, there's an MCH Journal article on our years of work that we wrote. But the core of it is really to engage families and communities as partners with health and healthcare and public health, and starting with aspirational goals like flourishing and school readiness. So we start to anchor what we do to outcomes and not just the removal of disease, and then discern and develop actionable data and tools that can then inform the transformational partnerships which are on the ground in the system locally, which ultimately is what's needed for change. And we started out with descriptive analytics, like who are our children and how are they doing? And then moved into more diagnostic, like how does it vary by whether children have insurance or medical home, or they're this age or that age, and all the demographics. And then predictive analytics started to coming in, where we start to see changes in policy, and we can start to see whether or not things are changing as a result of policy. And I'm here to tell you, unfortunately, they haven't changed that much as a result of policy. Some things have gotten better, but most things haven't. And so we still have to crack the code and look at prescriptive analytics on how can we make it happen. And a lot of why we see the gap is we're not implementing the evidence that we have. We've had for decades evidence on things that we can do. And so the implementation is the issue. And we know that's a whole science, but it's not like we don't implement some things. It's more, I think, that we aren't actually prioritizing prevention, health promotion, population health, and children and youth and families in this country. Even though people say they care about it, I think that we aren't matching those up. So that's why we have to keep going and keep doing more studies with more recommendations that align with the past, but keep the conversation alive. And in many ways, that's what NASM does, is it keeps the conversation alive, and hopefully it will stay the course in these next years. So launching Lifelong Health is from the National Academy of Sciences, Engineering, and Medicine. It was a committee, and I was on that committee There were about 12 of us. It's a small committee, and we actually do the research, believe it or not. It's a pretty intense thing. A lot of you have been on them, I'm sure some of you have. But to err as human, it was one of the first reports I remember in 1999 that came out that just showed how many people are dying because of preventable medical errors. And then crossing the quality chasm was really another report that you may know from a long time ago, also 1999, that was the beginning of the CAMI, which was really stating we don't measure quality and we don't base it on outcomes in actual health. And if we could do that and align payment, we could maybe get somewhere. And then unequal treatment, also really highlighting the disparities and huge disparities we have at similar levels of health issues, lots of disparities that we know a lot about. So this was meant to look at that in the charge of the committee, and it's funded by a public sector set of groups, mostly some HRSA and some private, some federal agencies support it, but mostly AAP, American Board of Pediatrics, and other groups like that. And the key here was to focus on health promotion and resilience and flourishing, with the recognition that we wanted to look at policies and practices that really, really went the distance on incorporating lived experience and engagement, because ultimately, if you're going to do health promotion and prevention, it's about engaging the people and the communities themselves, because so much of what needs to be done has to be done by people, right? In their living daily lives and in collaboration. It's not a pill that you need to administer. In many ways, as much as we're worried about immunizations, it's a little easier. If you can get somebody to give you their arm, you can put it in them. But when we talk about health promotion and prevention, it's all about engagement and trust and relationships. And to look at gaps and barriers in current payment models. We know a lot about the gaps that are there. Every day we see, stories about how we don't incentivize and measure and do the things we need to do. So we really need to just do what we know we need to do, but we don't have the research that we need where we're seeing what happens when we do this, that, or the other, especially for kids. We have more for adults, but so far it's not working very well because we often do payment models that influence one layer of the system, like a health plan, but they don't push down to the front line, to the actual people working with folks, and then they're still incentivized in a way that doesn't really support their engagement or trained. Next is, again, workforce, what I just said. We need a workforce that's different than the one we have. If we're going to start focusing on prevention, we're not going to be focusing as much on disease and treatment, because we know if we did a good job with that, we wouldn't need it, which is a threat, of course, to those who are already in the disease model. So we do have a lot of agreement that we need, relational health workers, community health workers, people out in the streets, in the homes of people, and to really anchor that as a core capacity that is funded, and that we can support those kind of workers as core team members with equal footing to those that are like MDs or licensed professionals. And then the last two are looking at levers to enhance integration across our public health systems. And so I'm going to actually go through this pretty quickly because I don't have a lot of time, even though it seems like a lot of time. But we have WIC, for example, for a long time, that is charged with engaging families and assessing what they need and getting them to services. We have Head Start, we have home visiting. We do a lot in this department on those three programs alone. We have primary care and healthcare. Everybody is charged with similar things, but they're actually not working together. And some of why they're not working together isn't because they don't care and isn't because they don't understand it's important. It's either capacity and also tools that relate to data. If you're going to assess development and you do it this way here and that way there, and you don't have any way to share the data, we just spend all our time trying to measure and not really acting on what we can do. So we've done a lot to try to solve some of the biggest barriers to allowing the systems and strengths in the systems we have to work with each other and solve for the different issues that are there. So I'm going to be talking a little bit about that. And finally is looking at promising mechanisms and policies to enhance collaboration and integration of data, which is what I was just talking about because they go together. So you must know that the current landscape is we are at the bottom of pretty much all other developed countries in child well-being across a number of types of measures. That we still, it's not just children in poverty, because actually children just above poverty also don't do very well, and even children all the way through the income realm don't do very well, but it's especially acute for the most disadvantaged, marginalized groups, and we know that there's a lot we can be doing there, and it wouldn't even cost a lot to do it. So we want to try to do that. Increased incidence of chronic diseases is true, and their comorbidity. we know a lot about accumulated risk and how it grows worse over time. And I think at a societal level, we're dealing with that, where it's not just at the individual level that we have a cumulative risk, but it's socially. We've now gotten to a point where so many people are experiencing, let's say, adverse childhood experiences and so much crisis that it's like a syndemic almost. And it's starting to show up in really concerning ways. Again, we have a lot we can do. So that's the exciting part. And we have infrastructure in place, but we're not leveraging it and integrating it. So in terms of health, here's some new data on child flourishing. This is just for young kids, that only about 29% are meeting at a high level of flourishing criteria we have in the National Survey of Children's Health, which really means that anybody below that needs something, and there's possibilities to promote a better outcome that are really key to school readiness, which is a measure we now have after 25, 30 years of work. And I'm not kidding you, to be able to even say, well, gee, should we measure school readiness? How would we do it? It's incredibly political, by the way. Measurement is technical, but it's more political, I think, than technical even. So you got to have all those skills if you're going to go forward to try to translate data and measurement into policy. You got to get all those skills going. So it's a good thing you're at this in this department for that one. But you can see here how dramatic it is. If you have 0 to 2 of these flourishing qualities, only 16.5% of kids are meeting basic school readiness criteria, which I would say is scored way too conservatively. I think it's the way it's scored is, a debate, but I think it's pretty easy to get a good score on it. And so it's already concerning. And only about 51% meet that criteria if they have 3, and 73.5 if they have all 4. So it's really this issue of, what we're seeing with positive health is that it needs to be positive. There's not like it's sort of positive. Like people who say, usually my doctor listens to me, when you interview them, it's really bad. It's like, well, they're not mean. They don't listen to me. So I'll say usually. Same thing with these kinds of positive health measures. It's kind of almost more dichotomous than you would think. Other things are a little bit more, linear. It doesn't seem to be as much that way. So here we are, and then 2/3 of 2 in 5 children ages 0 to 17 actually have a diagnosed health condition of the most common ones, and there's so much overlap. And it's huge in terms of the different kinds of conditions, but mostly there's a lot of comorbidity. Of almost 50% who have any one condition have another, so it's very hard to figure out. But what the main thing is in this graph, this is from a recent paper that we did, is about 2/3 of all the kids who have a diagnosed condition also have complex, evidence-based social determinants of health factors and or relational determinants of health factors. And our research has shown that about 60% who have relational health risk, like adverse childhood experiences, parents who aren't coping well, things that really can disrupt the safety, stability, and nurturance of the relational environment a child's in, which we know is so connected to brain development and well-being across life, do not have social determinants of health the way we classically define them in terms of food insecurity or economic burden or housing instability or unsafe neighborhoods. So we have to look at both. And that's different because in some ways, even though it's so hard to fix social determinants of health, it actually is a little bit more tangible than figuring out how to fix the relational context in which children live and how sensitive we all are to relationships and how we're seen. And in this time, I would say it's why I would want to elevate that we see each other, that we create a sense of belonging and mattering and connection among us, because we know that life is hard and won't actually probably get very easy. And it turns out that neurobiologically, all of us throughout life need that, and it's especially true for kids. So this is a little bit about what's going on. And the crisis in mortality for children and adolescents is mapping higher death rates also for adults and what we call the diseases of despair, things like suicide, substance abuse, and violence. And for the first time in America, sorry, I didn't mean to say that, this is the wrong slide. What do you think is the answer to how many kids are not or people who qualify, who apply to be in the military are not qualified, ineligible? Would you say, how many would say A? B? Okay, so quick answer, and RFK said this in his speech, actually, in front of whatever his talk was with his hearing this last week, is at 77%. And this has actually been that way for a long time. It's going up. But if you think about child health in the way that we think about it, I think that it's a value in and of itself. But in terms of our actual national security, our economic security is the future workforce. We have a lot of reasons to care about kids. And right now about 77% that are not qualified. And we have a lot of statistics that show us that most of the health conditions we have their seeds in childhood. So having kind of bummed you out a little bit, I hope will start to lift you up more in terms of possibilities. We do have also a lot of research showing that if we proactively promote the positive, even when we have adversity, we can actually be very protective. But we often focus on getting rid of something bad and not focusing on promoting something good at the same time in a dual continuum kind of way. So this positive childhood experiences research that we've been doing really shows that throughout all of life, it's also protective at every level of adversity. So we have a lot of adversity. We may or may not be able to get over it, but we do want to promote the positive. And again, those positive experiences come back to a relational base, feeling like you belong, that you matter, that you have someone you can turn to emotionally. We know what happens in our bodies when we feel triggered or stressed neurobiologically. I could probably sit here and say something to you that would actually activate your nervous system if I wanted to, in the way that I spoke or the way that I could say things right now and you'd be able to feel it in your body. So the idea that we're intimately connected and how we are with each other is very, very connected to our capacity to keep our brains online, and all that is really all this is about. And so how do we embrace that? So the possibilities are great. And a lot of the charge for the NASM committee was on promoting the positive, flourishing, school readiness, resilience, and not just on how do we get rid of bad things. Unfortunately, we're not investing. We're on the lower end, almost the lowest of the other developed countries, and our investment as a portion of national budget is going down also. So whatever you hear out there about needing to focus on kids, it's going to show up in this way if it's real. And so we got to keep our eye on the money. We do know also that the fertility rate's going down. So we know how it works in society, that there's going to be fewer kids kind of holding up in some ways, older people over time. So these are the things we're dealt with. And I'm not going to go over all the life course theory that you're going to take courses on, but basically it does mean moving upstream and focusing on early childhood health. Okay, so that was a lot. And now I'm going to go pretty quickly through this because what I'd like you to do is take some time to read this if you're interested. So I'm just going to give you a scan of what we're dealing with. First of all, the Launching Lifelong Health Report makes it very clear, integrating a lot of prior reports on what's the model we have now and what is it we need to go toward. And you'll see a lot of things like interdisciplinary teams, like bringing together home visitors and community health workers with medical providers. Looking at the health of the whole community, not just individuals, and so on. So there's a lot of, things that we've known about and have talked about for a long time. I was naive when I was younger, and I knew Cynthia when I was really young too. And I thought, well, once we get performance measures, we're going to fix it, right? Because then people will be held accountable and we will know what to do and we'll just do it. So it's a little bit humbling to see how far we have to go. So if you're interested in the models and the theory, there's a whole bunch in this report that talks about that. But before, I've already said a lot about it, but let me go right to the recommendations. So the first is to really begin with elevating the awareness and commitment of the public, because the public votes, and until we build awareness of not just the public, but also all layers of professionals who often don't know some of the basic things I just said to you. They mostly think kids are fine and they're not a problem and they're a low part of the healthcare cost, so we can just not focus on them. So we need to do that. And the recommendations are many. I'm going to focus on the public awareness campaign, which is a key piece, and say a little bit more of that throughout the talk. But also to have an expert panel. There's some things about this recommendation that align a lot with what our potentially new Department of Health and Human Services Director has already talked about, making sure states are empowered, enacting, well, probably not child health impact equity statements, but basically we should be looking at how we are impacting children and include that as a population and not just the general population, to look at it specifically for kids. And have an implementation plan that really goes the distance on implementing what we keep talking about. There is a lot of inconsistency between this report and prior reports. Our prior leader here at Hopkins, Tina Chang, and many of us on the committee are advancing a Children First for a Prosperous America that is focused on that public education piece. I'm also working with the National Prevention Science Coalition to do more of a Decade of the Child, which is focused on NIH and federal agencies and the legislature to support and fast track the research that we need to be able to, with confidence, say what works and what doesn't work, and put more in investment in the whole child approach, given that there are almost no children with asthma. There are only children with asthma, ADHD, mental health problems. There really aren't children with a disease. There are children who have a complex whole child profile, and often what's driving the problems are things that are not medical, but they show up medically, so we have to integrate. And that's really obvious as I say that, I'm sure, but the gap between saying that and doing it is huge. So this is what this is about, and it's a little bit like the Decade of the Brain, which actually fast-tracked a lot of the neuroscience research that we're now sitting with to help us with like the Neurons to Neighborhoods report. So we're trying to leverage that concept. And so I invite you to learn about that and wish us luck if NIH is reinvigorated. But if not, there's a lot of hope to kind of continue to just use it as a way to raise awareness. So the second is to finance health systems for all children, emphasizing prevention and health promotion, which is the big bugaboo. How do you do that when the benefit for payment doesn't accrue usually to the health system, it accrues to society over time? And so without financing in ways that really bring everyone into the fold and has a stake in it, it's going to be hard and has been hard. We do have performance measures. We do say the right words, but we aren't actually going to the streets with it. So there's a number of recommendations here that you can talk about if you're interested in financing. Certainly Medicaid and CHIP are representing about half of our of our children are enrolled, but it's very underfunded and we don't know what's going to happen there. And we certainly don't know what will happen with the prevention components. So most of our payment reform efforts, again, as I said before, are on older people. So this is a big one. And whoops, hang on. As the findings and the recommendations, again, are consistent with what I just said. So what happens is you give incentives, let's say to a health plan, like say you're enrolled, you get a capitated amount. So you would assume you'd want to keep people healthy, but then down at the provider level, it's still fee for service. So it's still the case that pediatricians can make 4 times more money doing an ear infection than a well visit. And, you know, I hear that all the time, that until that changes and I'm in a hard environment, I'm not going to be pounding the pavement, getting kids in for their preventive visits because I am already overwhelmed and I make more money this other way. And that's not something people like to admit, but it is the reality. So that payment reform is key. So kids are 38% of all Medicaid enrollees. They're about half of kids are in Medicaid, especially young kids are in Medicaid, but they're only 38% of all Medicaid enrollees because it's a lot of adults and they're 16% of total expenditures. So even at the state level, there's not a huge incentive to focus on kids because they're a small portion of the entire Medicaid budget for a state. And most people don't know that. And so we have to really, really be intentional to prioritize this because we care about population health and the health of our children. And so there is no way in my mind to do this work without being an advocate, because there just isn't a payment or financial model that's going to be a short-term return on investment that we can put our hands on, except for in small cases. We can talk about reducing emergency room, but it's so little money that most people don't take care, and the health plans take the hit, if you will. They don't care. They do bad, and they don't care that they do bad because there's no damage done for them. Ultimately, they have more damage by not focusing on adults. So we're in this place, but we do know that when we can invest in Medicaid, that we do see economic benefits throughout all of life. And we know this, that if we support early life well-being, the benefits go through to school readiness, school engagement, economic health, engagement in life, want them to be engaged in life. And with so many of our youth not even expressing they feel hopeful about their life. What do you think happens to a person, even with opportunity, who doesn't have hope? They often don't lean into it. So again, we're back to needing to be at the watch of our flourishing. Goal 3, strengthening community level health promotion and disease prevention, which is the heart and soul of this department and actually Hopkins overall. But we do underinvest. I would say that we do actually have a lot of investments going for our programs, but they're not connected. So if you look at Congress's view, they would say, well, WIC is underused, Head Start is underused, home visiting is underused, or people drop out. So from a point of view of a funder, it doesn't look like it's underinvestment because it doesn't look like it's being used and optimized. And also the outcomes are hard to put your hands on because ultimately good outcomes for translating into things like flourishing, school readiness, real concrete outcomes require an integrated approach, looking at the whole child. And often that's not possible because of the way the systems are set up. So it's again, why we're focusing so much on integration. Clearly, schools are important. The Launching Lifelong Health Report, if you're interested, has a huge amount about integrating public health systems and schools as putting that in the definition of the health system for kids. So not saying there's health care and then there's public health and there's schools, but that is how we would define the health system for kids is all 3. But keep in mind, before kids are in school, that's when there's a lot of developmental opportunities and they're going to healthcare more than they're going anywhere else at that time. They go to the doctor all the time. They're supposed to have 15 well visits in the first 3 years of life, and that's really under optimized. But here there's a number of recommendations, and I'm not going to go through all of them because of time, but we definitely want to expand funding for population health, family and child health, and that can turn into funding the infrastructure to help create that collaboration so that it really is sustainable and not just be leadership driven. So if you've got a WIC and Head Start program and healthcare that want to work together, they could probably put something together, but if you don't bake it in, that collaboration, it's very hard to sustain it. So there's a lot more going on here than I can say, so I'm going to go on, but I wanted to let you know that if we go toward states having more and more to do with schools, there's quite a lot in this report that have to do with what needs to happen locally, which is where the rubber hits the road. Goal 4 is a call out completely for the need to co-design and co-create with youth, family, and community voices and leadership. Again, if we're trying to promote well-being, we can't promote well-being for people, we can only promote it with them. And because the things that you need to do to be healthy are things you got to go home and do. And if there's not a way that we're connected and I'm listening to what works for you, what doesn't work for you. So we've sort of placed this in, it's a nice thing to do, but I'm placing it in, there isn't any way to create this cake called health outcomes without centering it on the engagement of the family and the community around things they care about that they will act on. And then you pull that thread and then all roads lead to Rome and it gets better. But if we don't start there, it's very difficult. So there's a whole section just on that and how to bake that in. And finally, this is the part, it's not the only part, but it's the part I spent the most time on. It was the measurement and accountability section, which focuses a lot on how we need to align performance measures across all these different programs so they can sing from the same songbook, we have incentives to work together, and so on and so forth. But just to get you right to some of the big things is first and foremost, anchoring our systems on population health outcomes. And we need to do some expedited research on some metrics. So we have metrics, I've shared some of them with you, but there's some gaps that we could fix right away. So we could start putting some measures out there. Accelerating through shared measures right now, let's say well visits or developmental screening are incentivized for WIC, Head Start, home visiting, primary care, but they're all measured slightly differently. And not that that's always bad, but they don't come together a lot because there's unnecessary variation. And there's also so many measures that you can spend all your time doing the measurement rather than really honing in. So that's a related recommendation is reducing accountability measurement demands by really prioritizing those outcomes and trying to rationalize the burden of measurement that's out there that's taking up a lot of time with no real perceptible benefits, and then providing sufficient leverage and incentives. So that I've already talked about that. And finally, this second arm down the bottom is ensuring engagement and transparency with patients, families, and communities. So when I started my career, it was family voices and engagement and getting data, but the whole point was to get it into the hands of people. So they had information and could start to play their role even as consumers in the health system, but they don't get the data anymore. Now we collect it. We collect a lot of the measures that we helped develop, but do you know about it? Do families know about it? They don't, and even if they do, it's sitting on some website with no contextualization or empowerment on how they can improve it. So that's a lot of what the CAMI focuses on, is how do we make sure that people get access to the data, that they get to think about how they can act on it. And so we do have a recommendation in here to have a national data dashboard, but also locally, so that there's a small number of things tracked with really a lot of proactive efforts to engage people, families, communities in the accountability system to have leverage. But at the bottom line, we're trying to get primary prevention into the drinking water of every community. And a lot of that, as I've said, involves working on how states through Medicaid and also all the local systems that play a role are coordinating with each other. And I'm gonna start to close so we have some time for conversation. But it's not meant for you to read this, but we do have something called the Engagement and Action Framework that really has a purpose of positive health equity. So flourishing, school engagement, family resilience as the outcomes. And then we have this one big doable thing, what we're talking about, which is we can think of a lot of things to do. But if we could just focus on, for young kids, getting them all in to every single one of the well visits through an e-door. And I'm going to talk a little bit more about this before I close, just to give you a sense, and you can learn more from me if you want. Getting everyone in with real engagement and partnership in a systems integrated way, where it could start at Head Start, it could start in early care and education, but we start to always move back into healthcare as well. And then we're addressing in here how to maybe do that very technically. It's not just a theory, it's actually building on a lot of the other proposals that have been out, including your proposal back in, I can't remember your framework for how policy impacts early childhood. So we've gotten into some minutia around what the policy levers would be, how you would actually deliver the care. So it really is an extension of the brilliant work that's been going on for decades to bring it down. And it focuses on leveraging existing systems rather than saying, oh, we need new systems that may or may not be there in 20 years. How do we take what we have? The pediatric well visit, it's paid for, it's required, there's performance measures, it's not happening a lot of the time. They're incredibly important places, and we can't reach kids just by focusing in healthcare because they're not coming in. We have to go out and work with the community and provide resources. I think I shared with you, well, no, I didn't share this already, that only about 56% of well visits are happening for young kids under 15. Or getting 55% are getting the well visits they're supposed to have, but that's actually 6 of 9. If you look at how many are getting all 9, which is that really sensitive time period in life, it's probably down near 30%. So we have the data from Medicaid. So it's really bad, actually. So the utilization is low. For decades, we've measured developmental screening. It's still only 1 in 3 kids getting developmental screening. And of course, that's got to be a beginning of something. And so we want to create the integration. And these are the different programs that need to integrate and bring healthcare in, because that's where the young kids are actually going and where there's a lot of financial benefit for the system to cover those services there. And acknowledge the overlapping goals and functions. So CCD, if you look at it, it almost makes you laugh. And I have a document you can read on the statements of what all these different systems are required to do. And they sound exactly the same in many ways. And yet it's not happening anywhere. So that's a lot of what EnAct's about, creating a through any door approach to enable wherever families go, wherever the trusted broker is, giving them tools and resources and the infrastructure to work together. So I'm not going to go through anymore, but I will say that to stay the course, we want to leverage existing strengths, support collaboration, really actually try to implement the recommendations this time and not just talk about them. And maybe we have a chance, and that we have a lot of frameworks and tools to build on. So with that, I will just say we do have new studies on how the public feels. There does seem to be a collective caregiving model that Frameworks Institute, which is a communicating organization, thinks is salient to all of the population. And this most recent JAMA study did show that a lot of Americans at all sides of the aisles do understand the importance of early childhood and well-being. And they may disagree about who's responsible and how it should happen, but the fact that there's an agreement, to me, is something we want to leverage. So that's my talk.
Thank you so much. Well, I can kick off discussion. This was amazing, and thank you for that very comprehensive roadmap. I think it's very exciting and inspiring, especially these days, to see a path forward. In terms of questions, we usually start with students. Do any students have questions?
Yeah. Hi, thank you. It was a really great talk. I was wondering if you could talk about the financial investment into programs versus into families specifically. I'm thinking about like the stimulus that families got during COVID and how that ended. And, you know, I don't know where you think the impact has the biggest bang.
Well, I can say something about that, but there might be somebody in the audience who is an expert on that. Is anyone here? And we know that the small investment we made, you know, addressed poverty and improved a lot of things for families, and now it's gone away. So there is a lot on like making prescriptions for money, like even $85 for pregnant women having an impact. So there's more and more research happening that even small amounts of financial support direct to families is key. But it's still the case that you have to reach families, get into relationships with them, and start to work with to even capture them for resources that are available. So it's happening very intermittently. It's not a national program, but there is some research. Does anyone know more about that?
Well, I would comment, it's a very important point you're raising. The tax credits during the COVID period in 21 reduced child poverty from approximately 12% to about 5.6%. It was an extraordinary experiment, really a mass experiment in what can be accomplished in terms of creative approaches. I think this has been ignored since over the last couple of years. Certainly this year, nothing will happen, but I think that's a critical issue.
And we have here that about 66.6% of this representative survey of Americans support child tax credits. It's higher in some groups, so
Well,
but it's not happening. So
there was another element to it, and that was that tax credits were irrespective of whether you worked or not. So that was another dimension that really enhanced tax credit availability. So it was really working through IRS and social the general population rather than someone who had to work to then get a tax credit. It was a very clever system that Biden had, the administration had.
Thank you so much. This is fantastic. This graphic in particular is one of the most reassuring things I've seen in recent days. And I'm wondering what kind of you alluded to thoughts on what working with either state governments or whatever agencies look like when this sort of free fall passes.
when what passes?
What feels like a free fall of government?
Oh.
When whatever the rearrangement of institutions, departments, like, you know, whatever the new administration has in mind for federal agencies, I guess. When that stabilizes, my fear is that so many of the systems that you have talked about won't be functioning in the same way that they were. And so I guess, given that people feel this way, what do you feel like are the paths forward in the
Well, I think that's why, and I really want to give Tina Chang and Jim Perrin and the leaders of the committee. I was a committee member, but that's why it's goal number one is the public education and engagement. You know, many people have spent many years trying to figure out what the right messaging is, and surveys like this are part of it. But we have to really, you know, be involved to try to prevent what you're saying from happening. And then we still have a little time and we're trying, but also at the state level, if that does happen, they probably will get creative, some of them. But we'll have to start to track the implications and come back around, and hopefully when we do have a more supportive context, we'll fix it, but we need to be at the watch of it. And also recognize there is a lot of creative leverage, even if there's no increases or any of these changes happen, there's a lot that can be done now through relationships and partnerships that there are within the scope and reach of a lot of these federal we supported programs that are at the state level that are not happening now. So if we can, encourage creativity, even if we can't have our ideal, I think we can still, maybe we'll come up with some new things. You never know. But we do need the public education campaign to really put pressure on preventing that and restoring it if it does happen, but also to really look at how can we make it work. It's part of why the threat is there is that it's not looking like it's getting better. So it does look like we're supporting all these programs and kids are getting worse. So we don't know what we're doing. It looks that way. You can imagine why it would look that way. And so some people think the solution is to get rid of the program. But that's not it. It's that we're not looking at the whole person. Maybe they can get WIC, but they're not getting Head Start, or they're getting that, but they've got, okay, so we have to start to do that integration, I think. I've already said too much, so that's a little bit for you.
Thank you so much. I have a question regarding your biggest recommendation is getting children into home visits, and more, I don't know if more of a question or just like a mental exercise or just raising this to everyone, sort of ideas surrounding like the very real fear that parents, children, everyone is facing in regards to deportation, and that safeguards being taken away in hospitals and settings. I don't know if like what maybe people's ideas are, or what your thoughts are regarding what can be done to like.
Well, again, before I say
or-
something, I'm wondering if Allison wants to speak to that.
Well, only that's very real and at the top of everyone's minds. There were already a lot of barriers to accessing services. Fear was one of many, and that's certainly heightened right now. So I think it's a great question, and everyone's really struggling with that for sure. So
I
thanks
mean,
for
whoever
looking
the
at it.
family feels is already their trusted broker, it's very important to the extent that families have someone they trust. And also, we work a lot on empowering families directly, where they can actually learn a lot about their child's health and development and figure out what to do without having to go into the system. So our Well Visit Planner tool, for example, educates families starting from birth, 1 month, 2 months on what's important, how's your child doing, here's some resources. And so it takes out the middleman so we can empower them. It's in English and Spanish. They don't have to share their name. They own their own data. So there are resources like that that are actually working especially well with the Spanish speaking population. Because oftentimes, they just need to know what's going on and then have resources to reach out. It has to be that trust and relationship. And that's why we need to have that relational infrastructure to fall back on when things are hard. We don't have it already. It's hard to create it in the middle of a crisis. I'm even feeling afraid to talk to my colleagues openly right now, not because I don't trust them, but because it's a scary time. So I think we want to really just, if you have a relational system already and a home visitor is perfect, but then you want to empower them with resources to optimize their own well-being, even if they don't feel like they want to go into the formal system.
I'm excited about that too. I know we've talked about it, and I'm excited to see whether it could be measured. I know, as we said, like as you just said, it being confidential, but also I'm excited to see whether it could be measured, like use of that tool
Yeah.
during this time.
Well, I mean, Community Health Center in Austin's using it. They're at 12,000 completes of the Well Visit Planner. And it's almost all Spanish speaking families, and they are like, why don't I have this? And they choose whether they want to share their data. If they don't trust the system, they can still get the information and resources. And the engagement's better, and now they have time in the clinic to actually address the issues. Now, why that wouldn't scale like wildfire, I don't know. That's what I've been talking to Allison about. It's kind of, it does address a lot of the barriers that we have, but we still live in a system that doesn't really want to empower people. To be honest. Very respected people for me tried to help me understand that, so I stopped taking it personally. It's really about that. But for consumers to take hold of these things, if they can learn about them, they're free to do it. We can free the people. There's a lot we can do. Because a lot of what we need is actually not rocket science in terms of family, in terms of healthy development. There's a lot we can do.
Yeah, integration of services has always been a focus of mine, but almost impossible to achieve. There are so many different elements to it. First of all, within the professional circles themselves, there's a sense of territoriality.
Yeah.
There's an unwillingness for the feds to take this on. My own view is that Medicaid, as a payer of extraordinary amounts of funds, should be central to the issue, where something like a health passport is part of what the Medicaid card provides, and that providers need to be incentivized, but also not permitted to turn away those who have such a broad health card, if you will. What do you, where do you go with this?
Well, I mean, first of all, you started with where I think it has to start, that when you can get people together, and I call it building relational systems of care. So just as we need families who feel like they have a trusted broker, if I'm in WIC, Head Start, early care and education, healthcare, child welfare, early intervention, all these programs that are there that have similar mandates but are not working together, they often start their conversations together with a certain amount of skepticism and distrust, because they've often been really, really realized, and they want to make sure they can still meet their guidelines because they're afraid of being defunded as well and not looking good. So if we can get them together, build that relationship and align their incentives, because they're so close already, and actually give some resources to create the interface and a shared vision. So we understand that we actually agree on what we're trying to do, and they don't even know that they share goals and performance measures. So that goes a long way, and is what we did in Mississippi. And people started to relate. And so that's one piece. The second is the practical issues that you spoke to around the health passport. So when we talked with each one of them, once they would talk, because that was a whole thing of who am I? Why would they talk to me? You know, I'm some outsider, so the trust building. It was, well, we can't actually work together if we don't share a standardized way to do assessments. Because I'm just going to measure something like development, and the doctor's going to ignore it. This happens all the time. Head Start measures development, but the doctor does it again because they don't trust the Head Start teacher because they're not an MD or whatever. Same thing with home visitors. So creating a standardized approach, and that's what the Well Visit Planner does in our case, is it would allow a WIC provider or a home visitor to do a, you know, evidence-based validated assessment based on national guidelines that they could then share through a data portal that's secure and family driven. So the family gets to agree to share with the provider or with early care. So you give them a way to do the engagement of the people with measures that they don't have to like become expert on scoring, because the system scores it for you with resource links, and then they actually have something they can do together. So the big key is, if you want people to work together, you got to give them something to do together, not just theoretical. So a lot of people get tired of going to meetings to talk about collaboration because there's nothing that ends up being actionable about it. It's like if you walk away thinking, oh, I should be able to do this, but there's no tool. And so that's where the passport is exactly right. And that's a lot of how I would describe some of in the engagement and action framework. Something like that needs to happen. Now we've created a version of that is there, but however it happens, there needs to be some way that everyone's empowered to engage families, support assessments that help us figure out what's needed, what the priorities are, and what they need, and then link them to that. So I think you're right on track. And I think WIC would be an amazing collaboration. We talked about that a long time ago.
Well, I didn't want to be provincial and raise WIC, but I've tried it WIC. I've just recently talked with the outgoing folks at WIC. I've talked with Secretary Vilsack at length. I've talked with NWA. NWA has National WIC Association has their own territorial interests, although they're a wonderful organization. The feds, FNS and USDA have their own series of constituencies that seem to make this so difficult. I'm just,
And they're almost saying the same thing, but in slightly different ways. It does start to look like it's just about territory and ownership. And the Federal Interagency Council on Early Childhood, I presented to them on January of 22nd of this year before the next day, and they didn't know if they were ever going to meet again, because that was the day just after they were told they couldn't have any more meetings. So it was the last meeting. But it's been a lot of work to get like Head Start, child welfare, early intervention, and early care and education, and CMS and Medicare to work together. Now, I didn't see USDA or WIC in there, but it is all about what you're saying. So it has to be, I think the federal government can do a lot by organizing and connecting themselves. But if you don't listen to the states of the people, ultimately it's not going to work. So I think that however the incentives are rolling to create the kind of fear that keeps people closed instead of open is the fundamental place we need to begin. We have to create openness to change, talk, do it differently, learn from each other. And without that, we're going to keep sabotaging even the best looking partnerships that work. But I say free the people in the meantime. Give them resources and tools and let them know what they can get and can't get. People don't know. They don't even, but parents are not educated about child development in a public health kind of way, or given tools to self-assess and access tools. And there's a lot we could be doing on that track at the same time. But I'm hoping it can change, because I've been at this for a long time and I feel like I have too. And when it comes down to that relational infrastructure, we have to start prioritizing it. And it's also true for kids in health, where the relational context of the home is driving a lot of the variation in how kids do, even with the same condition. So I think this is the common relational approach, and that's why it's called engagement in action. It's about engagement in a holographic way at every level.
thank you.
Yeah.
Great thought.
That seems like a nice note to end on, I
Yeah.
think. Christy, thanks so much. I really appreciate your cross-disciplinary approach in particular, and being able to, bring together some of the big players and have these conversations. So thank you so much for this enlightening and thought-provoking.
Thank you for inviting me.